Shim, give my phone. Phone. उसमें होगा रूम में बेडरूम में देखियो. Okay. Hello to everyone. I hope I'm live, audible, visible. If I'm live, audible, visible, I will start the session. And after my session, we have our beloved great Jasser session. And one more good news, okay? The chanting notes are made from our Jasser only. So that's why you will not have any problem in going out through the notes, okay? So that's why these notes are actually Jasser notes. So Jasser notes I use to create the chanting material. So that's why those who attended Jasser class or will attend his session, they will find it very complimentary. It's like I'm just putting a tadka slightly, like he make proper biryani, I've just made a Maggie. So this Maggie will be very, very interesting. So that's why it will cover important topic in my way, but it will cover important things, okay? So I'll be starting another 2-3 minutes, okay? And this is the first session here where we'll cover mainly trauma, general surgery, all the important things. Plus next session will be covering the systemic surgery part, which is I think tomorrow. So that's why this, okay? Yeah, after me there are Jasser sessions, so I'll do rapidly things so that Jasser can explain his topic, his style, and I will just give my talka from medicine point of view, especially shock or Glasgow Coma scale. So I will give my inputs into that. So that's why it will help you learn much better, and that will be very, very beneficial. So there is, I don't think, any chance of postponement or something. So that is the case. So Jasser surgery notes are my material. So they are the material for, so they are the base for chanting. So they are created from that, okay? So concise way, okay? PDF again, as obviously I've already given you a folder. That folder I keep uploading the file. So the link I have given you, that G drive link will contain the, so G drive link I have already given you. If not, I will post in the groups, you can copy, okay? So hello to everyone, please join in. I'm starting the session now, okay? Yeah, I will do remaining session later, okay? We don't know if exam get postponed, maybe I get more time, but right now it is just one thing, that exam is most likely not going to be postponed, what we feel from all the activities or the hints. So that's why I will request, yes. Should I start? Okay, I think let's 1 or 2 people more join in. Yeah, so we'll continue. Good evening. See, I posted it in the Google Drive. You can message me for any doubt. 9899529468. You can send me Telegram or WhatsApp. I will reply. Telegram or WhatsApp. Okay, so let's start. So yeah, I'll give the G drive link, and I even post in, if you open any old video, you will always see my folder. I'll just show you. See, just go and type, like you go to YouTube, and in YouTube just write DBMCI and you will see the video. Like I'll say DBMCI, all the video I do post. Like example, let's say there's a video, it's just going on. So let's say I took a physiology session. So see, in the physiology session, again I have uploaded the link, like in reply, etc. I'll just show you here. Sorry. So I will just give you in the live section, go all the sessions I took, I always upload. Like example, Dharma, look at the reply. See, in the reply I will always be posting, okay? Not posted here, I'll post, okay, don't worry. Anesthesia, see, all the replies are having the files. Can you see? Where are they? I posted the folders. I don't know where they went. I am telling the truth. I did post the folder links. I don't know where they disappeared. So you message me, I'll send, okay? I don't know where they went. I posted in reply of each and every reply. Every reply I posted, I don't know where they went. So do one thing, you message me, I will send the link, G Drive link, okay? Maybe they are not there. Chalo. So I think we'll start without any delay. So first we'll discuss is trauma, and trauma use what? ATLS, okay? So ATLS is the guidelines we are using. First is tries. Tries means you want to sort out. Why? You cannot give equal attention to everyone. Your time is limited. So need to do segregation. That is, we are discussing which patient need first, second or third attention in this case, okay? So first question is, it is done in mass casualty like a train accident or a bus accident where, or earthquake just like in Turkey. So we'll have red. Red means red light. Remember, red means red light. Stop. Immediately you stop and attend the patient. Life threatening. Okay. Remember golden hour. So they are the one which can be saved during the golden hour. Yellow means what? Wait. Remember yellow traffic light. What is yellow? Yellow means wait. So yellow is wait. That is, there is a injury but doesn't need immediate. And green means what? Green light. Green light means go. Go. That is, you can see the patient walking, maybe some fracture, maybe some abrasion, but they can go home. So we can discharge also, they can be going. Okay. Now comes the question black. Black means iska to band ho gaya. It is almost dead, pulseless or dead. So this patient is dead. We need to, yes, ignore it. So black means gone. Tata, bye bye, dasvidaniya. So now comes the survey. We have a primary survey in which you just see what is the patient main problem. Then we can do an elaborate examination. So primary survey is for triage. Secondary is when we are giving a detailed examination for the proper treatment. A, B, C, D. This time they ask you what is D. D means disability prevention. So D is disability prevention. So that's why there's a cervical injury. We need to do it as soon as possible. Otherwise, it can lead to what? Permanent paralysis. So that's why neurological is very important. So A is airway, also restriction of cervical spine movement. B is breathing. So B is breathing. And as I always tell you, if there are mistakes, please forgive me in the file, spelling mistakes, they do occur. Breathing. So airway, breathing, circulation, and also there is disability is environmental exposure. So always check the scene for safety, check the response, basically carotid pulse and respiration, and not responding, call for help. Okay, call for help. So they ask the order, always we check the response and we will call. So first check the safety, then check the patient, then call for help. Okay, don't call for help before, maybe they are just acting or sleeping. Okay, so call for help. Okay, now obviously talk. If the patient can talk, that means the airway are okay. If not, maybe airway injury or maybe head. Both are serious conditions. So both are serious condition. Okay, so this is chanting. I'm just doing a rapid recall of important concept. Sir will discuss in detail everything and he will give you the spatial features. Okay, fine. Now if the patient can't talk, obviously it's head or airway injury. Then if airway is compromised, you will find tachypnea. Why? Because as airway compromised, there is decrease in oxygen level which stimulate the chemoreceptor, causing a rapid respiratory rate more than 18 per minute. Then also the patient use effort, so it causes accessory muscle like sternocleidomastoid. You can see the neck showing this contraction, or there could be sounds. So sounds are there which indicate airways compromise, or tracheal shift is indicating what? Maybe indicating what? Pneumothorax, maybe, or hemothorax. So pneumothorax or hemothorax can be there, or cyanosis not occur now. Why? Cyanosis is because of hemoglobin becoming what? Reduced. It take long time. So cyanosis is not an early sign. Earliest sign would be rate accessory muscle sounds. Okay. Now secure the scene. Then we do manual inline stabilization, which is by chin lift, jaw thrust. This I discussed in the case of what also? In anesthesia also. O2 mask is given and we can use the cervical collar to prevent the, yes, neck injury or mainly affecting the cervical spine. C3, C4, if they are injured, it can cause diaphragmatic paralysis and very dangerous. So what they do? Prevent injury to cervical spine, and we know C3, 4, 5, which nerve? Phrenic nerve supply diaphragm. So it's very, very important. So that's why it's very important. Now, this is anesthesia also, definitive airway and adjuvant airway. So definitive airway is endotracheal. It's a secure airway, where these are not secure. So they are definitive secure airway. Why they are secure airway? They don't cause aspiration and they are not going to move. So they are secure airway, and they are adjuvant like oropharyngeal airway, nasopharyngeal or laryngeal mask airway. Okay. So that is the main thing. Secure the airway and cervical spine maintenance. Now, Glasgow Coma Scale. Okay, if less than 8 or equal to 8 or SpO2 less than 85, they both indicate a definitive airway to be given to the patient. So definitive airway must be given. Okay. Now comes breathing. If you are checking breathing and a patient is having any breathing disturbance, what could be the reason? It could be a tension pneumothorax or a massive hemothorax. They both cause severe respiratory distress. So now what the concept? In case of pneumothorax, it could be simple or tension. Now what is the main thing? Understand, in tension there's a very high intrathoracic pressure. So there is very high. So I'll just write down, in tension increase ITP, intrathoracic pressure can be more than 30 or 40. So very high. Here ITP is 0. So it's ITP, intrathoracic pressure. Intrathoracic pressure. What is the reason in tension? There's a ball valve mechanism. So there is what form in tension? In tension, there is a ball valve mechanism. You just write one-way valve. Now, what does this one-way valve do? So there is a one-way valve. So that create what? Air to come but not to go out, and that causes air buildup. So that causes air buildup, and that create high ITP. And this high ITP collapse lung and push the trachea, mediastinum to other side. That's why it's a very serious condition. It's a tension pneumothorax. Let me show you. So what are the findings and the feature we will see in this case? So this is your tension pneumothorax. You can see. So this is the collapsed lung. This is the air which is present, and this is shifting the trachea to what? To the opposite side. So this is your tension pneumothorax. Are you clear? Okay. Now, if there's a tension pneumothorax, what happens? There are severe respiratory distress. BP is low, JVP is increased, but there is absent breath sound because the lung is collapsed. So no breath sound, plus ear will cause tympanic, that is hyper resonant on percussion. So when you see tympanic note, that is very vibrating, like drum ki tarah, dholak ki tarah baj raha hai, dham dham dham, like this. So that is a tympanic note. Whereas if it is simple, the ITP is 0 and it's mostly a open pneumothorax. It's mostly a open pneumothorax. In this case, what happens? There is no hypertension, no increase in JVP. Breath sound can be absent, and yes, there could be hyper resonant, but main thing is it is not an emergency. What is the emergency? It is a emergency. Okay. So why? Because of buildup of pressure, it can be very plus pressure, very high. So positive pressure, here 0 ITP. So what is the emergency? Emergency is your tension pneumothorax. Okay. Now remember, if there is absent heart sound, then we suspect what? So remember, hypotension, increased JVP. If with what condition? Absent breath sound, that is tension pneumothorax. If absent heart sound, it is backstride, it is your cardiac tamponade. So remember, if heart sounds are absent or muffled, then it is cardiac tamponade. So remember this, very simple. I will just summarize everything. A patient come in emergency with low BP, with increased JVP. If breath sounds are absent, suspect what condition? Suspect your what condition? Tension pneumothorax. But if heart sound are absent or muffled, then you should suspect what condition? We should suspect cardiac tamponade. Very, very important finding in this particular case. Are you clear now? Now question. In case of the tension, it's an emergency, we need decompression, we insert a needle, the needle will make the high pressure leak out. So what it does? It causes air to come out and decreases ITP. As ITP decreases, the lung can inflate again and breathing can continue. So that is why we are very, very important to do what? We do needle decompression. Now remember the concept. It is very simple. It is done in the 5th intercostal space mid axillary, so mal. So remember, mal in adult. So adults को mal चाहिए, mal. So what adults need? Mal. Mal means anything, okay? So they need something mal. Whereas if children are small, so in children, so chest tube, in children, it is second ICS. And what children need? They need what? So they need MCL, mid clavicular line. So remember, children, mid clavicular line, adult, it is anterior axillary. So mal or MC, mother. So who need MC? Mother. It is children. Who need mal, adult? A. So A for adult, A for auxiliary, and children C. CC. So children is C. So remember, second. So children are small, but remember in pediatrics, okay, in pediatrics. But later on you put chest tube. Chest tube is put in both fifth intercostal space in mid axillary line, and it is same as what? Same as the needle decompression, triangle of safety. What is the location? Triangle of safety. Okay. In case of open or the simple pneumothorax, we will do chest x-ray. We can wait and do chest tube. So here, remember the summary. Pneumothorax final treatment is chest tube. In the triangle of safety, fifth intercostal in the mal, mid axillary line. But in case of tension, we need to do decompression with needle insertion. In adult, same location as chest tube. But in children, pediatrics, we will go with what? Second intercostal mid clavicular line. So it is the mid clavicular line is this concept. Am I right now? So don't make a mistake. It is very, very important for to understand. Okay. Now, and if there is absent breath sound, what you will do? Yes, we will do pericardium. We have to puncture and take the fluid out. So that is pericardiocentesis. So remember, needle decompression if breath sound is absent. If there is heart sound absent, backstride, we'll do cardiac tamponade. That is the case. Okay. So remember, this question is given. Okay. Okay, there's the injury hyperresonant. So we are discussing it is pneumothorax. But here BP is normal. If BP is normal, we will not suspect tension pneumothorax. We'll suspect open, and in open we'll do X-ray and insert the chest tube. X-ray and insert the chest tube. Okay. Now comes the open wounds. I'll just leave. This is the triangle of safety. Remember, it is between the two muscles. What is that? Latissimus dorsi and the pectoralis. Is what? Lady between two major. Remember. So same way. This is pectoralis. This is making the anterior border. Behind is the lateral body of latissimus dorsi. Dorsi is sounding like rassi. Dorsi, rassi. Rassi we use for climbing. So that is the climbing muscle. So latissimus dorsi ko high altitude. So take you to high altitude. And the base is the fifth intercostal, space is there. Okay. So that is the case. So apex is made by axilla. Anterior is which muscle? Pectoralis. Behind is latissimus dorsi. And this is the triangle of safety, fifth intercostal space. Now remember, we'll use what? Upper border of lower rib. MCQ. Why? Because vein is passing. What is vein? Vein is vein, artery, nerve. So to prevent the injury to the which? Injury to the nerve. So that's why to prevent the injury to the nerve, we will use. If you want to do what? If you want to do nerve block, then we'll go the lower border. So the order, vein, artery and nerve. Vein, artery, nerve. So do you want to injure the nerve? No. So to prevent the injury, we will go in the upper border of lower rib. Are you clear? For nerve block, what you'll do? You'll do reverse. We'll go in the lower border. Okay. Now, if there's a massive hemothorax, it is very similar to tension pneumothorax. So how do you differentiate? The answer is, in this case, again, there is hypotension, decreased BP, rapid breathing, distress is there, and there is what? Breath sounds are absent, and trachea again can be shifted. But what is happening in this case is JVP can be decreased, percussion is dull. Are you clear now? Percussion is dull. Why? Because there is a pneumothorax, blood is there. So percussion would be dull. So if there is dull percussion, decreased JVP, think of hemothorax. So it is hemothorax. Okay. And if there is what? If there is what? If there is resonant, then it is air. It is tension pneumothorax. I hope it's clear. So tension pneumothorax. Okay. Please message me for the PDF. Okay. If you message me, I will send the PDF. This is my number 98995294. I have made a G Drive link, and this drive contain all the PDFs. You can just check and get it. Okay. So I'll send it to you. Okay. Fine. Okay. So 9899 529 468. Let's move. Okay. Now C is shock. That's circulation. So the most common cause of shock, it is hemorrhage, and it causes hypovolemic shock. Okay. Now in hypovolemic shock, it's a cold shock. Why? So it is a cold shock. Reason? There is an increased sympathetic which cause vasoconstriction, and that's why the body periphery is cold. So it is called as the cold shock. So it is called as the cold shock. Now non-hemorrhagic shock, what is there? Like example, tension pneumothorax or neurogenic shock, or also anaphylactic, they are warm shock. There is bradycardia. Bradycardia is also in which condition? Vasovagal shock. Vasovagal shock also. So if there is a bradycardia, we can suspect vasovagal and septic shock. Fever, think of septic shock. So what are the other conditions which can cause bradycardia? It is vasovagal shock, septic shock, and also our neurogenic shock. What is the reason? Decreased sympathetic. MCQ. So decreased sympathetic cause neurogenic shock. There is a decreased BP, bradycardia, and it is warm shock. Reason? The blood is there in the body, so it causes warm shock. Okay. Now, as I told you, cardiac tamponade is what? It is trauma causing accumulation of blood. It's a type of what? It's a type of your what condition? Pericardial effusion. So it has a backstride. Okay. What is the backstride? Hypertension, increased JVP, that is distended neck veins, and also muffled heart sound. Muffled heart. We do what? Pericardiocentesis. For treatment here, we will go for pericardiocentesis in this particular case. What we do? Pericardiocentesis. Let me show you. So this is the treatment here, pericardio. So what do you give in case of patient with the tamponade? Pericardio. Best is ultrasound guided. If not available, we go sub-xiphoid approach, okay, which is blind approach technically. So ultrasound is best. Okay. Next question. Here itself also in JVP, what do you see? There is X is present in JVP and Y is absent. So this is a question asked. So X present, Y absent. X present, Y absent. Okay. That is the hallmark here. Now classification, I will teach it in my way. We will not see this and I'll make it easy for you. Just follow my command. I'm discussing classification of shock. So understand in shock, especially hypovolemic or hemorrhagic shock, just remember the golden rule. The golden rule is in shock, there is an increased sympathetic. This increased sympathetic will increase the RAS, increase the heart rate, and it will try to increase the BP, try to correct the BP. If it can correct the BP, if it correct, then two things are possible. What? BP can be normal or BP can be low. Low means less than 90 SBP or 90/60. Now, what is the concept? If BP is low despite loss of blood, this is called as compensated shock. And if the BP start to fall, it means the compensation is not adequate. It is called as or decompensated shock. Decompensated. Now one more concept we use is as BP is falling and the heart rate is increasing, we use something called as shock index. Okay. So also it is called as stable shock and it is called as unstable. Why? Because the BP is falling. And with the criteria, we use something called as shock index. What is shock index? Very simple. I told you in shock, what is happening? In shock, there is a decrease in the BP and increase in the heart rate. This is also called as Mary's law. So BP is falling and the heart rate is increasing. So BP is falling and the heart rate is increasing. What is it called as? It is called as our shock index, SI. So that is why what happens? Normally what will happen is, understand, the formula is heart rate by SBP. Now understand, if both are 90 and 90, you'll get one ratio. Understood? So now if the heart rate is above 90 and the BP is below 90, what will happen? The heart rate will exceed the SBP. That means it is more than 1. So more than 1 shock index means it is unstable. So what happens? SI will be more than 1. And if it is less than 1, that means heart rate is less than SBP. It's a good thing. If your SBP is 100 and heart, then it will be what? Less than 1. That means BP is more than heart rate. That means it is stable. So that is shock index. And also sometimes we use modified shock index. It is better. Why? I'll tell you. Modified SI. Modified SI use what formula? It uses heart rate but by MBP. So heart rate by MBP. And what is the formula to remember? If they are giving what? If they are giving shock index, SBP is used. If they are giving modified shock index, MBP is used. So that is the concept. So MBP is used in case of modified shock index. So modified shock index, MBP, shock index, SBP. More than 1 indicate the patient is unstable. Less than 1 means heart rate is low, BP is more. That means he is having stable condition. Okay. Now remember, the stable shock or the compensated is class 1 and 2. So class 1 and 2 are normal BP, and 3 and 4 is a decreased BP. So that's why they are uncompensated. They are uncompensated, unstable shock. These are stable shock. These are the stable shocks. Okay. Now see a very important thing. What is the criteria? 1 and 2 are technically together. That's why treatment here is we give what? We give blood. Here treatment is we give the IV fluids. Okay, we'll prefer crystalloids. So we'll prefer crystalloids. So we'll give the crystalloids in the patient. Crystalloids. Okay. Now comes the question. Very simple. Okay. Shock index is SBP and modified is yes MBP. Okay. Now I'll make it easy for you. Remember, like me, you will never make mistake. 1, 2, 3, 4. 4 is 40%. 4 is 40%. More than 40%. The shock is more than 40%. Then this is 30 to 40%. More than 30 but 40%. This is 15 to someone say tennis score. So 0 love, 15 love, 15 30, then 30 40, and then game point. And 1 is 0 to 15%. Now the normal blood volume 5000 ml. So what will be the 10%? 10% is 500, 15% is 750. So it is what ml? It is 0 to 750 ml. This is 750 to 1500 ml. And this is 1500 to 2000 ml. And this is more than 2000. Are you clear? Now what about the heart rate? I told you heart rate. I told you very simple. Here normal, that is less than 100. Here 100 to 120, 120 to 140. Here more than 140. Easy. So here it is more than 140. BP I told you here BP is maintained. Here it will be fallen. So that's why here BP is above 90. Here the SBP is less than 90. Are you clear? Then respiratory rate will increase. So here will be increased respiratory rate, and then urine output will decrease. What is happening? UO, RR. UO will be normal, slightly decrease, and there is oliguria. Oliguria. What is oliguria? The urine output is less than 0.5. Less than 0.5. Okay. ml per minute. I'll just write it later. Okay. So it is 0.5 and 0.3. Okay. And in case of RR, it is increased. So it is more than 20, more than 30, more than 40 per minute. So let me just make this table for you. So this is our table for the shock. So remember this table, I'll show you the table. See, first question. So what is 15%? It is 1. What is 15-30% is 2. That is compensated. More than 30 to 40 is moderate, and more than 40 is severe. Or the heart rate less than 100, 120, 20, 40. Pulse pressure, don't do, just remember, keep falling. Why? Because as the BP fall, pulse pressure will also fall. Leave it. Hypertension, I told you BP is normal here, BP is decrease here. Respiratory rate less than 20, 20, 30, 30, 40, more than 40. This I discussed already. And what is the urine output? I told you here oliguria occur. Here urine outputs low, but not very low. Here oliguria occur. Patient might be unconscious, need massive blood transfusion. Massive blood transfusion. Now, clinical feature obligate tachycardia. Why? Because of increased sympathetic, hypotension, can't walk, unconscious, oliguria, all are the features. Stable, unstable, I told you. Hemorrhagic, we have to, yes, control the bleeding. What is the fluid? We have to give 2 wide bore needles we can insert for giving. So I'll make a mnemonic to remember the what? Cannula. So I'm discussing cannulas. Use my formula, okay? Use. We'll start with our Earth, our planet Earth. So what is there at the core of the Earth? Earth core contain lava. So lava is there. So lava. So lava is there and lava is there. Then Earth is containing its gray color coverings. That is the Earth. That is soil. Okay, that is soil. Okay. Now in the soil, a plant is growing. Plant, okay, plant. Too much big. Plant. Don't say doesn't look like plant. Aap sahi hai. Now most girls love which color of flower? Pink. So there is a pink flower. Pink. So there is a pink flower. Then what is on the top? If you see the blue sky. So what is there? Blue sky. Then on the top there is our sun. Sun is outside the atmosphere. This sun. And as you cross the solar system, this is sun. As you cross the solar system, there is space. And space, Thanos is there. Thanos. And Thanos, remember what is the color of Thanos? I'll use internet to get Thanos. What is the color of Thanos? Anyone? What is the color of Thanos? I'll take the photo of Thanos. Anyone? What is the color? Yes. He look purple, but I'll take it violet. So Thanos. What is the Thanos is there? Okay. So let's start now. Now you will never ever forget. First question. What is the color of Thanos? We'll take violet. So violet is Thanos. Okay. Purple, violet le lo bhai. Chalo. So let's start. So what is the idea? Lava. इतना गर्म होता है लावा सब जला देगा. Like 14 Feb. Love na 14. So what is the size? 14 gauge. Then soil will be 16. Plants are 18. Okay. हरा भरा. 18 पे हरा भरा होता है. So what age we become हरा भरा? 18. Pink flower 20. Sky is 22. Sun is 24. Remember, sun is 24/7. Remember, we need 24/7 sunlight. 24. And Thanos will be 26. So 26 is Thanos. So he killed everyone. So he is killing. So 26. So you remember it. And remember, between the soil and the plant, there could be white. So between the two, white it khatra mein 17. White it 17 mein khatra. 17 khatra. So I hope now you'll never forget. Lava is orange. Then soil is 16. So earth core, this is the core of the earth. This is earth. Core is lava. Then soil is there, which is grayish color. Then green plant, pink flower, blue sky, sun is 24. And finally space, Thanos come, violet color is in the water. Okay. So I hope you enjoyed this summary. This is the case. So what are the widest one? They are the widest ones. And which is the narrowest? It is the narrowest. Done now? So 24 and this. Done? Okay. Let's continue our studies. Okay. Now, sometime we can also use in the lower limb great saphenous or short saphenous vein. Okay. Clear? So they are not used for IV cannulation. But mainly what's happening is sometime we can use intraosseous, that is the proximal 1/3 of the shin of tibia, or we can do a venous cut section, also called as venous section, or we can put the cut down. Okay. Now balance hypotension or hypotensive resuscitation, all this basically maintain the BP 90 mmHg. Now what we can give 1 liter bolus crystalloid like ringal lactate. Okay. Or then we give blood and blood. The ratio is 1:1:1. Like packed RBC 1, fresh frozen plasma should also be 1, and the PRP, that is platelet, should also be 1. Now fluid of choice is crystalloid, RL or normal saline. Now best fluid is blood, obviously, which you have to do cross matching, and if not having any matching like A positive need A, we can give O negative. So O negative is universal donor. Universal donor. Okay, so universal donor. Okay, I'm already taking chanting session of, I think this is my 7th subject. Okay, I've covered 6 already: physio, pediatric, psychiatry, then I discuss which one, FMT, then I discuss the derma also. This is, I think, 6th or 7th. So done already these sessions. Anesthesia also. So this is my 7th session. Okay, fine. The best goal for adequacy is always urine output. MCQ. What is the goal? It is 0.5. Remember I told you 0.5 or less means what? It is oliguria. Okay, and it indicate what? Risk or injury of the kidney failure. Okay, and 1 in pediatrics. So 0.5 per kg per hour in adult, and this, and what it indicate? Less than 0.5 in risk or injury. Risk of injury rifle criteria, which I'll discuss later. Rifle criteria. So rifle criteria use 0.5 for risk or injury. Okay, 0.3 is failure. 0.3 is failure. Is renal failure. 0.3 is renal failure. Okay, now remember, so output, that is prognosis ki whether kidney is working or not, depends on urine output. If you are not able to give enough perfusion to kidney, it can't make the urine. So that means the treatment is not adequate. So urine output. But how much we need to give? Best is given by pulmonary capillary wedge pressure, because that indicate left atria pressure and perfusion of the right ventricle. And since it is not, second best would be CVP. So what is the best? Best is our pulmonary capillary wedge pressure, but that is difficult to do. It's very invasive. So we can use a central venous pressure. Am I clear? So that is for amount of fluid given. And if there is poor, we add dopamine. So we will add dopamine if oliguria. If oliguria persists or oliguria. Am I clear? So what we need to add? Oliguria need to be added in this case. Okay. See, I take session whenever days are available. Like if other faculties have days, then I will not be able to take. I took on 18, then I took today. So I will take whenever slots are available, and I've already given the schedule in the main group. Okay. Chalo. Now neurological is Glasgow Coma Scale. We check the GCS, Glasgow Coma Scale, pupil and lateralizing sign. Okay. I will discuss it very soon when we discuss the GCS. Now environmental exposure is basically to prevent the hypothermia, need to cover, and yes, we can give pre-warm fluid 39 degree. Now adjuvants, obviously pulse oximetry for SpO2, ECG for any arrhythmia or anything, ABG again for acidosis, acid base, X-ray chest and the pelvis for any trauma or any any blood loss which is not visible. Okay, so that is why anything which is what not observed we need to do. And E-fast is sonography in trauma. So that is extended focus assessment sonography in trauma, very important in this case. Okay, fine. Chalo. Now comes the question, log rolling. So it is said it is 4. Okay, so that is we check the patient for injuries in other areas. So that's why if there is a limb injury we can see, then we can do additional 1 more. What are the total number of log rolls? So 4 log, 4 बातें करते हैं ना, 4 log. So remember 4 people do 4 talk, 4. If lower left, 5. Now DCS we know is what? Disseminated coagulated this syndrome. So what is the reason of DCS? So in DCS basically what is happening? The death triad, coagulopathy, clotting disorder can cause what? Emboli formation or prevent the clotting factors from being used later. It can cause hemorrhage. So very dangerous coagulopathy. Plus there is acidosis and there is hypothermia. These are the 3 what? So sorry, damage control surgery. So DCS, what are the triad of danger? It is acidosis. That's why we do ABG for that. Then hypothermia, we check the temperature, and finally coagulopathy. Okay, so obviously what is that? Hypotension plus triad, we will do, yes, damage control surgery, control the bleeding and decrease the infection. Then if disease, we put the ICU, and 3 is in the OT will give. Okay, OT. Now head injury, what is happening? Increase ICP, there's a loss of consciousness, vomiting, seizure, headache, or any bleeding from ear or nose. That indicate what? A head injury. Now signs is basically if there's a injury to the anterior fossa, then it can, anterior cranial fossa, it causes the panda or raccoon eye. that is the blood will accumulate, okay, around the orbit, that is called as panda eye. If there is middle cranial fossa, it causes the battle sign over the mastoid. It's a very commonly asked question. That's the case. In both, any head trauma, any injury, it is the case. So it is always NCCT. It is your NCCT. Okay. Now let me teach you GCS in a very simplified manner. Understand the GCS in my way. Okay. So GCS is a three-part: I, EVM, I, verbal, and motor. So I, verbal, and motor. Okay. So I, verbal, and motor. So remember, I, 4. So there are 4 eyes, 2 patient, 2. So 4 eye, and say 5 word. 5 words. Which 5 words? I will get good rank in the exam. So what 5 word we need to say? I will get good rank. I will get good rank. I will get good rank. Okay. And finally, motor is hit a 6. Chakka maar do. Hit a 6. So hit a 6. Chakka maar do. So what is the mnemonic? 4 eyes. 4 eye. 4 aankheं मिली. 5 word बोले. I will get a good rank and hit a 6. So I. What are I? 4, 3. So remember, 4 is patient is spontaneously opening the eye. So spontaneous opening. 3 is what? He opened the eye on command. 2 is on pain. 1 is not opening. 1 is not. Verbal, I'll just make it easy for you. 5 is normal communication. 4 is confusion. How to remember? 4 लोग 4 बातें करते हैं, 4 और confuse करते हैं. 4 people confuse us कि do this, do that, do that. Then 3 is inappropriate words. I'll just write words. And 2 is sounds. So he'll say 1 is no sound, nothing. So it is none. So once again, what is normal communication talk? It is 5. Confusion is 4. Words, inappropriate words. Kutta, sale, harami. So this is MCBC words. Words is 3. And sound is he's making sounds. And finally, it is none is 1. And if non-testable, we put NT. What does NT means? Non-tested or non-testable. Non-testable. Now 6. This is very important. Most people are confused with motor, so I'll try to make it easy for you. All the confusion I will explain with the help of physio medicine. 6 is basically what? Patient is having what? Normal movement. So it is normal. He follow the command and tell. So number 5 is what the patient do. He will localize the pain, site of pain. So ask him where the injury, he can point. So localize the site of pain. Okay. So just show it once. Okay. So obey the command. It is first. So it is normal. Obey command. Obey the command. Now 4, 3. That is the most confusing. I will make it easy for you. 4, 3, 2, and 1. So please understand. 4 is basically withdrawal to pain. Withdrawal to pain. So when you give a painful stimulus, the patient move the limb. So that's why he will move the limb. That is called as withdrawal to pain. Now 3 and 2 are abnormal flexion. Where? Upper limbs. And it could be already present or on pain. Okay, so patient, when you give painful stimulus, he might show abnormal flexion. That is 3. And it is also called as decorticate rigidity. So the name given, decorticate rigidity. So the name used, decorticate. So remember, what is decorticate? The upper limb are flexed. MCQ. So patient has flexed upper limbs, but lower limbs are extended. Lower extended. Upper is flex. So flexion of upper limb is called as abnormal flexion or decorticate. What is the reason? If someone asks you, rubrospinal tract. What is the reason of flexion? Rubrospinal tracts. So they are producing, and that means the lesion is, yes, keeping the rubrospinal tract intact. It is much higher up. So it could be mid-pontine lesion. MCQ. So mid-pontine or mid-clavicular lesion is there. If there is abnormal extension that is upper limb also extended. So now the patient is like this. Hands are also extended, legs are also extended like this. So if you see this patient with hands also extended and the leg, this is all extension. E, extension, extension. So if double extension, it is called as decerebrate. Decerebrate. So how to remember? In case the upper part, cortex, upper is flex, and in this case, upper is also extended, lower is also. So E. So what is decerebrate? Upper is extended. Decorticate, upper is extended. Decerebrate, lower, upper, both are extended. MCQ. So if everything is extended, it is our decerebrate. One is nothing, none, no movement. Okay, so please remember this. It's very, very, very important. What is the minimum score? Minimum is 3, maximum is 15. Maximum is 15. So minimum is 3, maximum is 15. That is the Glasgow comma scale. Are you clear? So that is the case. So abnormal. So that is the case. They can ask you if it's tube or we cannot do, it is called as T or NT. NT is not testable. Okay. Now, what is the most common head injury? It is, yes, contusion followed by your subdural hematoma. Subdural is what shape? Sickle shape. This I've covered in medicine also. Sickle shape. So subdural is sickle shape like this, concentric, and sickle we use to cut the bridgings. So bridge, cut the bridge, very common in boxer. So remember, subdural is sickle shape and it is in boxer. Acute within 3 days. If after 20 minutes, called as chronic. Mostly elderly fall. History of fall is there. Okay. Now comes the question. This is the case. Now, if there is a severe sudden headache, that is thunderclap. Okay, thunderclap. It is SH. It's most likely Barry aneurysm. This will cover in our medicine also, and that is at cow. What is cow? Circle of Willis. So that is your circle of Willis. Okay, and it is not having any peculiar shape. Why? Because the blood is in the sulcus, and you can see it as some branching pattern. Okay, and severe headache. Why? Because blood is an irritant. So here blood in CSF. So if there is blood in CSF, severe headache, thunderclap, it is Barry aneurysm. Treatment is clipping and coiling and decrease BP. What do we use? Hunter Hess scale. What is the scale we use? Hunt and Hess scale. Okay. Hess Hunt scale. Treatment is CCB and clipping, coiling of aneurysm. So clipping, coiling of aneurysm. That is the treatment of what? Of your Barry aneurysm in subarachnoid hemorrhage. Okay. Now, if in ECT, if you see idli shape, idli, it is idli shape. Idli. If you see a idli shape, this is your EDH. Idli, EDH. Idli, EDH. Am I clear now? So idli is EDH. So idli is EDH. And remember, who make the idli? Ma. Idli is made by Ma. So Ma is middle meningeal artery. So who make the idli? Ma makes idli. Meri Ma. Ma. Middle meningeal artery. Middle meningeal arteries. Okay. Now most common site is temporoparietal area. There is a lucid interval. That is, patient become normal and again become unconscious. And also there is a lateralizing sign. Very important. One side pupil is dilated and opposite side body is weak. That is, paralysis is there. That is a very important, that there is a hematoma. And where the hematoma? The side where pupil dilate is the site of this. This is called as lateralizing sign. So what is happening? Opposite side body. Why? Because if there is right cortex, right motor cortex is affected by hematoma, is compressed. So it will affect the left body and pupil will dilate on the same side. So that's why same side pupil dilation and opposite side, there is contralateral hemiparesis. So contralateral hemiparesis and same side pupil is called as a lateralizing sign. It's called as a lateralizing sign. So what we should do? We should always do a evacuation of hematoma by, yes, Burr Hall craniotomy. So we'll create an opening, craniotomy, and we will extract the hematoma, called as what? Burr hole craniotomy. Okay. So NCD is what? It is bilateral. Okay. Now subarachnoid I told you always barrier aneurysm. It is at cow. What is cow? Circle of Willis. And what is the most common cause spontaneous? It is rupture, mainly elderly. What is the scale? Hess and Hunt scale. And what is the treatment? I told you CCB and coiling and clipping. Mainly we give here nicardipine can be used. Okay. Fine. Diffuse axonal injury. So what is that? Diffuse axonal injury is the worst head injury. Clear? There is shearing tear between the gray and the white matter. So there are very few finding, but severe. So what? NCCD is normal, but there are severe sign and symptom. Severe sign symptom. So what is patient? Unconscious, not responding, very poor. You can say neurological findings, and there is what? So that's why investigation choice is MRI, MCQ. So which condition we do MRI better than NCD? That is your, yes, NCCT. Okay. And there is finding is what? You can see retractions and axonal walls. Okay. Yeah, we'll use nimodipine. Okay, sorry, nimodipine. Okay, not nicardipine. Sorry, nimodipine or clevidipine can be used in this case. Okay. So CCB. I've discussed that in CCB. Clear? Nimodipine. Okay, fine. Now comes a question. So this is a diffuse axonal injury. So also in head injury, there's a Cushing reflex. Cushing reflex, what happens? There is a decrease heart rate and increase. It's a reflex bradycardia. So decrease heart rate and increase BP. Okay. And if there's a decreased BP, it is a bleeding. So that is the case. So if there's a bleeding, okay, that is the concern. If BP is low, that is a bleeding case. If BP is high, it is Cushing reflex. It is Cushing reflex. Okay. Now primary objective in the management of head injury is what? Decrease the intracranial tension. What is the marker? It is papilledema is there. Also there is papilledema. So increase ICT. There is also papilledema. On fundoscopy. So what are the medical and surgical? Surgical is obviously burr hole craniotomy, shunting, that is CSF. We shift to the peritoneum via ventriculoperitoneal shunt. And if medically we do hyperventilation, what is the purpose? Hyperventilation cause decreased CO2, and decreased CO2 cause vasoconstriction. Because I told you, what does CO2 do? It causes vasodilation. So it will decrease the blood flow and causes decreased CSF pressure. So that is the medical method of what? 100% hyperventilation. Are you clear? Plus we'll do elevation so that it allow the fluid to drain out. Plus we have to maintain normal volume. Don't let the BP or pressure increase further. Hypertonic saline and osmotic diuretic, they cause loss of fluid. Plus neuromuscular blocker will make the body move less. Less muscle activity will make the brain require less activity energy. Otherwise, if you move the muscle, the brain will need more energy for motor cortex neuron. So you want to decrease brain. Plus they all cause decrease brain activity. So they will decrease brain metabolism. Benzodiazepines, barbiturate. In fact, we can use even general anesthetics also. So decrease brain metabolism. And if there's a decreased brain metabolism, it will cause less hypoxia to the neuron. So that is the case. But remember, steroids have almost no role in lowering the ICP. And if there's a seizure, we have to manage the seizure. That is done in medicine. So I'll not discuss the seizure in this case. So we can skip. Okay. So now we have a look at what? The other parts of the general surgery. So there are some topic which we are doing now. Some will do it later. So let's see the general surgery. First is we are having, okay. So first is there are two kind of sutures. One is absorbable and non-absorbable. Now first is absorbable are basically broken by the enzyme or phagocytes will do. Okay. Now what are the absorbable ones? So I'll discuss first. There are two types, synthetic and natural. Natural catgut, as you all know, name is catgut, but it's not obtained from cat. It's difficult to get the cat and kill them. It's mainly from sheep or cattle gut, mainly submucosa. So submucosa is used for this particular purpose. Okay. Target BPC, understand. If you are asking target BP, it depends. Okay. In case there is, let's say, a patient with any stroke, the target is, if it is ischemic stroke, the BP should be what? Only and only reduced when it is more than 220 by what? 120. Okay, so if it crosses that value, then we try to decrease the BP. But otherwise, in case of hemorrhagic shock or hemorrhage, target is 140. So the target 140/90 is the target in hemorrhage. Ischemic, the target is only decrease the BP if it cross 220/120. Otherwise, do not decrease BP in ischemic. So conditions are different in both. Okay, fine. Now in sympathetic, we have the vicryl or the monocryl. So these are two cryls. Okay, vicryl and monocryl. Okay, natural is catgut. Catgut is obviously made up of protein. So since it is made up of proteins, it is very easily broken by various proteases and peptidases. So that's why get absorbed within 7 to 10 days and completely in 60 days. Okay, whereas vicryl is made from polygalactin. So if it is made by polygalactin, again it is a type of, you can say, sugar only. It is broken down completely 90 days. So once again, what is faster breakdown? It is catgut suture, which is 7 day it is broken, and it could be 60 day completely absorbed. Okay, now monocryl is also, yes, there, and it is absorbed in 90 day and again start. So monocryl and the vicryl. Okay, fine. Now there is also chromic catgut. It is having chromium to delay absorption, so that's why it can stay for longer time rather than completely disappear in 60 days. It can stay for much longer. So remember, catgut start in a week and within 2 months it's over. And what increase the catgut suture retention? Because as the suture is absorbed, it become weak, and weakness can cause the wound dehiscence. It can open up. So that is why we can increase the life by what? Chromic catgut. So it is increased. Then also we have the PDS, that is polydioxanone. So it delay the absorbing suture, but it will also be absorbed eventually after 6 months. That is 1 days and start 2 weeks. So let's revise once again. Or the three synthetic ones, they are cryls: vicryl, monocryl, and the PDS. Okay. Now what is the longest? PDS is long name, so it is lasting much longer. So PDS is 180 days. Okay. What is 90 days? It is monocryl and vicryl are 90 days complete absorption. Catgut is just 60 days. If you increase by adding the chromium, it is called as chromic catgut. Okay. Now comes non-absorbable. There are two types: synthetic and natural. Natural are what we make clothes. So what are they? Silk and linen. Silk we obtain from the silkworm, and it is braided. What does braided means? It has, yes, grooves. So like we have now here, what we do, girls, they do braiding now. So braiding is when you make the fiber crisscross. So that is called as braid. And now synthetic, two type, they are braided and non. Nylon is a straight fiber. Then proline is also straight fiber, which is also called as polypropylene, and polyester. Polyester is braided. So remember, which are natural? They are silk and lining. They are braided because the threads are made by braiding the fiber obtained from what? The silkworm. Whereas nylon and proline, they are straight fiber. They don't have the braid. They are straight fibers. Okay. So which are straight ones? Nylon, proline. Okay. And which are the braided? It is polyester, which is braided. So polyester is the braided one. Okay. Now one more is monofilament. Mono is obviously non-braided. Okay. And poly is obviously having multiple. So they can be used to braid. Choti banate choti. Braided is this. Okay. Now what is the main thing? In case of poly, there are grooves. And these grooves where you have the braids, infection, bacterial growth can occur. So it can cause bacteria to grow. So that's why bacteria grow in the groove of the braids. In mono, obviously there is no space for bacteria to grow. So that is the case. Okay. But knots, bacteria can again grow. Allergic reactions. So obviously natural are mainly having proteins. That's why they are allergic. Okay. So what is allergic? Natural. But obviously if you are using what? The nylon, etc., risk is not there. Allergy risk is less. Okay. Now numbering, as the number increase, there is a increase in the thickness of the fiber is decreasing. Okay. So increase thickness fiber. So there's a one is thicker, two is, and the strength will decrease. Inflammatory reaction will also decrease because there's less fiber. Fibrosis is less, scar is formed less, but it will be weaker one. So that is why we will have to make a compromise. You want strength or you want complication. So less complication with a thinner one, but it is also not giving good strength and wound closure. Okay. Finally, so that is the main concept. Okay. So higher number of sutures for scarless in the case of face is cosmetically better. Now 3-0 and 3-0 vicryl is braided, and this is mono. So now question is, if it's non-braided, it will be having less secure. Why? Because braids have groove cause better locking and secure knot. Whereas in the case of this, there's a suspicion. Okay. So there is, yes, infection can occur more commonly. Okay. So more suspicion is as suspicion. Now what can also have a memory, that is go back to the previous shape, that is in the case of the, yes, monoclinic. So if you turn, it can go back to the unturned form. Okay. Now all wounds are closed in layers except the midline laparotomy wound, which are not closed in layers. Okay. Now what is the absorbable? I'll just leave this part, we can just skip it. Okay, not the main thing. What I'll focus is which is asked. Okay, intestine repair. So in this case, we always connect what? We will first close the mucosa and the submucosa, that is inner layer, and serosa and muscularis. So that is why it's not closed in one but in two. It's called as sutures repair. So remember, intestine, we never close the two, we close the one and the other. Are you clear? And if there is a single layer, that is external extra mucosal layer, then we do a Matheson single layer repair. Okay, here we use the PDS or silk. Now bone, we have to obviously need, the sutures are not good, so here we use steel or platinum or proline, which is non-absorbable. Okay, tendons, again non-absorbable, we'll use the proline. Vessel, again proline. Then if it is HJ or GJ, we use vicryl, or we can use our what? It is PDS or silk. Okay, PDS or silk can be used. Okay, now comes the question, margins are everted in the vessel repair, called as a Carroll's repair. Okay, so are you clear? So we'll use the Carroll's repair. So what is the margin in the vessel? It is everted. Okay, in the case of Carroll's repair. Okay, now these are some photo. This yellow show 3.0 what? Catgut. It is polyester green, blue is nylon, this polyglycolic is I think Thanos, purple something, this is bluish, this polypropylene, that is proline, and also there is what? Silk braided, which is black. Okay, so these are the case. I don't have much idea because I also have not been to surgery department for a long time. Now understand, all wounds are closed in layers except I told you mid laparotomy wound, it is closed in continuous mass closure. MCQ, all are. So that's why all are closed in layer. Like in GIT we close mucosa, submucosa, then muscularis and the serosa. But in the case of what? Laparotomy, it is done all called as mass closure. Okay, and we use what? Proline. So it is used proline. And what is the ratio? Suture is to wound ratio is 4:1. 4:2, called as the Jenkins rule. So remember, laparotomy we use Jenkins rule, mass closure, all layers together use the proline, and ratio of suture to wound is 4:1. 4:1, 4:1, 4:1. Okay. Okay. This is the case they are showing. Okay. Aberdeen notes. Okay. So there is no tail ending continuous because using one. So no tails. Otherwise you see tails. There are no tails in case of continuous, called as Aberdeen's knot. Okay. So that's the case. Now three types of closure: interrupted or continuous closure. Okay. Then continuous can be either simple or mattress. Okay, in simple we have this x to x rule. Okay, where we have to leave a gap of 2x and the distance of 1x. Okay, so that is distance from the margin, and the distance between the two is equal to 2x. Okay, let's say it's 1 centimeter, so it will be 2 centimeter. Okay, that is the margin distance. Okay, so margins are sharp and clean, matrix are there where irregular are there. Okay, so if there is irregular, we use vertical matrix. If sharp and clean, we can use the simple suture. So simple is for clean margin, matrix if there is irregular margins. Remember, matrix is irregular, and what is the this simple, that is the case. Okay, so I'll skip that part because it is now not. Just remember, secure or reef is as name, square is secure, square secure. Granny, old granny cannot tie very, no, so granny ke haath bhi weak hai, weak. So grandmother is weak, so granny is weak. Granny is weak, and surgeon are the best. So surgeons is the best. Surgeon is the most secure. So MCQ, or the most secure, surgeons is the most. Okay, weakest is granny, which grandmother ties. Okay, so this is square note, this is your granny note, this is surgeons, and surgeon is the most secure. Okay, These are the knives. Okay, so remember, curve is for suture removal. Okay, sickle shape, 12 number. 11 is straight, it's for stabbing, for abscess drainage. Okay, then minor surgery, we use the 15 number, very short blade. Then bigger margins are there in the 20 number, and most commonly used for laparotomy, thoracotomy is your 22, 23, 23. So straight one is 11, 11 सीधा अंदर जाएगा, काट देगा. 11 is for stab, 11 stab. Curved is 12, suture removal. So let's revise. 12 is curve, 12 is curve, suture removal. 11 is straight, stab. 11 is straight, it is for stabbing. Then we have the 22, 23, 24. They are most commonly used for major surgery, laparotomy or thoracotomy, etc. Okay. Please remember, it's very, very important. Humphrey's knife is used for the skin grafting. So take the skin graft. In case of burn, we need to put a skin graft. So how do you take? It's Humphrey's knife. So Humphrey knife is used for what? Skin grafting procedure. Okay. Then this is power dermatome. It can also be used. So power dermatome and the Humphrey's knife are used for skin grafting. Okay. Now needles are there. I'll not go in the needle much. Okay. So I'll just skip. Wounds, I'll discuss. What are the classification of wounds? Okay, so factors which affect wound healing are multiple, like site of wound. Okay, some area are difficult to heal, some are easy. Okay, structure involved, then presence of contamination, how much tissue is lost, blood supply, insufficiency, radiation, pressure, the nutrition, immunity, diabetes, smoking or any chemotherapy, uremia, kidney failure, malignancy, obesity. So many things are there. So we'll just skip and come. Rule is Langer's line. Okay, they are the line of the arrangement of the collagen. So that is Langer. Langer is collagen. Collagen, Langer. La la, la la. So remember, Langer is collagen. Lagen, Langer. And if they are skin fold, so that is the line of the resting skin tension. Skin fold, skin tension. It is Crassel. So Crassel is what? So Crassel is what? So it is our skin tension. And what is Langer? Collagen. Collagen is Langer. MCQ. So we always give incision parallel to these lines. Okay, because that will cause better healing. If you do a transfer section, difficult to, yes, make the collagen fiber fuse. So that's what's difficult. Okay. Now, what the healing occur by? Primary intention or secondary or delayed primary is also called as tertiary intention. So remember, primary is the best. So it's mainly occurring in which condition? It is you bring the edges of the wound by mechanical means and it causes what? Better healing in this case. Okay, and we can use suture, staples, clip or glue. Okay, now secondary is basically we leave the wound open and we let it heal by granulation tissue. So take more time. Okay, more time. Okay, then come delayed primary or tertiary. Okay, in this case the scar is better than secondary but not than primary. So that is why what caused the maximum scar, it is the primary. Then number 2 is delayed primary, also called as tertiary. So what is delayed primary also called as? It is also called as tertiary. So let's revise. What is primary healing? It is your scar is better than the secondary and the delayed. Then what is secondary? You leave the wound and that's why it is having less trauma, less involvement. So that's why it causes less scar. Okay, but causes more granulation tissue, whereas delayed primary is via tertiary intention and it causes what? It causes scar better than 2. Okay, what is the golden period for wound closure? 6 hours and decisive is 4 hours. Okay, else there is contamination and once it gets contaminated it is difficult to heal. And yes, clear. Most common is obviously Staph aureus, which is causing multiple other infections on the skin. Now classification is very important. So what is the classification of the wounds? First, clean. So class 1 is clean. They are basically only skin organism like the commensals of the skin in a controlled environment. So best results are obtained. So what give the best results? Clean wounds. Now clean contaminated are exposed to the skin but also our GIT bacteria, respiratory tract or the urinary tract. So that's why they are having the bacteria from these areas. So that is why it is contaminated. Bacteria is there, but it is under control. So it is under the control. Now contaminated is not controlled. It is outside organism coming. They could be staph, pseudomonas, klebsiella. And dirty is if you leave the wound, bacteria grow and causes the spillage of infected material of the wound. So that is the case. So what are the four? First is clean wound. There is only the normal skin microorganism, but there are no bacteria which are there like E. coli there in the GIT or respiratory or urinary. So remember, three tracts which contain bacteria are GIT, anaerobes are also there, then also gram negative, then respiratory tract and urinary. If these are exposed or involved, this is called as clean. So that's why all GIT surgery, all surgery of airway or the urinary tract will be type of clean contaminated. Okay, whereas contaminated is exposed to the outside world which is giving the bacteria, and finally it is dirty. Dirty is what? Contaminated wound if left alone more than 4 hours. Remember the golden period we discussed? So that is the concept. Okay, so after 4 hours the wound will be, yes, contaminated and cause the formation of what? Pus and spillage. Now that's the case. Okay, so surgical site SSI is what? Its surgical site get infected, and it is most common cause of post operational or post OT morbidity. Okay, how do you prevent? So obviously we have to start with proper cleaning before the surgery, that is disinfectant, and scrubbing is very important. So scrubbing with chlorhexidine in alcohol base 5 to 7 minutes, and we always go centrifugal, never paint, will always go centri from the umbilicus. Nipple to mid thigh MCQ, where we go nipple to mid thigh, last is genitalia, and here are not shaved, clip the hair. So here are clipped, not shaved. MCQ are clipped, not shaved. This is the question asked recently. Okay, next question. Airflow should be there, laminar airflow using a HEPA filters. Okay, ultra clean is needed in cardiac, ortho or normal surgery nowadays. Okay, here removal, I told you, here is clip, not shave, and we should give prophylactic antibiotics. So what we should use? Prophylactic antibiotics. Class 1 wound, we don't need that profile. Why? Because you're only having skin commensal. Okay, so class 1, no need of prophylactic, we can give antibiotic later. If it is 1D implants, we need obviously 2, or class 3, 4, we always need the antibiotics in this case. And the best time to give the antibiotic is, it is the time of induction. Okay, best is 1 hour, or if not 1 hour, 30 minutes is the case. Okay, so it should be 1 hour or 30 minutes, because it takes time for antibiotics to act in the body. Okay, now malnourished people have more risk of infection, so that's why we need to increase the nutrition. And yes, we have to stop the smoking 1 month prior to surgery. As we have discussed, what is the most common organism? It is Staph aureus in surgical site infection. Classification we use is Southampton's, and score is asepsis score, a sepsis score. Okay, so I will finish here because I have to give break for the next session to start. We have covered almost 25 to 30% of the surgery. So remaining surgical point we'll do tomorrow. You attend third session because I have to catch a flight. So tomorrow we'll do the remaining topics. So we'll wrap up today here. Okay, so I'll be taking optha also later. So we have still left with what? We have done 7 subjects, and we have still left with the remaining 10, 12 subjects. We'll do them later. So tomorrow we will start, okay, and do the remaining of the surgery. So tomorrow is the class of the remaining surgery. I will wrap it up now. Okay, so I will wrap up the session now. Thank you very much for coming. I'm very, 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 yes, happy to have you all on board. Okay, thank you very much. PDF, I'll upload this PDF. I will also save the changes. Save and close. So this file is saved. I will upload it on the what? Okay, and then I will replace it with the updated file. Okay, so thank you very much. Yeah, tomorrow is the class. Okay, tomorrow. Yeah, all braid are polyfiber. Obviously, baat hai, you cannot have a braid in single fiber, na? So single fiber cannot be braided. Okay. So bye bye. Take care. Good night. Let's meet soon. I don't know the time, maybe 6 or 10. I'll update the time once we see, okay?